Today I am going to be joined by Partha Kar, who has led and advised on diabetes care at national level for 7 years. He balances this with his consultant endocrinologist role at Portsmouth Hospital NHS Trust, one of the busiest on the South Coast. He is an active public speaker, medical writer and author of opinion pieces. And Partha has led work that has undoubtedly had a really positive, life-changing impact for patients and a huge impact on patient safety. I wanted to speak to Partha today because I wanted to ask him about how he has managed to drive forward such significant changes and the role that patients have played in that as part of that journey and support, and talking a bit about the techniques he uses to drive forward change and influence decisions. So you're very active on social media and you talk directly to quite a large community of patients with type 1 diabetes and people who care for patients with type 1 diabetes. And you keep that community updated really well through video updates, your posts, you share correspondence you've had from the NHS, within the NHS, and you also really encourage patients and their carers sometimes to get involved at a national level in consultations, and you're very good at explaining why that's important and why their voice needs to be heard. I guess my first question is really in making yourself very visible and approachable, you're engaging very well with patients, and I'm wondering what you think is important about engaging with patients and their role in helping to drive forward changes and patient safety improvements.
So I think what most people are looking for from people who are doing leadership posts is probably honesty and candor as to what can and cannot be done. I think as national leaders, overarching, there's a view that they won't understand, the pressures that we're under, and people don't quite get it. People get it. People understand. People live their lives every day. They can read the newspapers. They know the NHS is under a lot of pressure. But I think one of the big challenges that people face is that there's a lot of decisions generally made about them without any involvement of them. And I think I'm very open about, this is what we're doing. It's not going to be for everybody to begin with, but we'll get there. We'll need your support. And I think that is wholly appreciated by people, because I will not come out and say things which I'm not going to be able to do. And I think that level of being honest about where we are with, for example, right now, we are hopefully getting close to getting the artificial pancreas or the closed loop screw. But, the conversations are, it's not going to be for everybody to begin with. And it's not because I don't want to, I would love to, but we don't have the workforce, we don't have the money, so we need to work our way through it. So, and I think that's appreciated a lot. So my message to anybody doing this role is, and as you been doing it for a long time, it really helps you in the long run if you're open to people. So that's my view of looking at things.
Absolutely. And I think, what you're saying about we need your support, and that's very much a collaborative approach, isn't it, with the communities that you're serving, which is always really important in driving safety changes.
I think it's also, what I always also add to these, it depends as to how you see these roles. And, are you somebody who's cascading information from top, or doing the things that you've been asked from top down to the people you're supposed to be serving? Or are you the inverted way, whereby you're taking everything from the community and putting it upwards? And I think a majority gets stuck in the first one, where they're like, okay, I've been told that that's all I can do, so I'll just tell you this is what we're going to do. While my approach has been, look, that's what the community wants. Now let's be honest about what we can do and have those negotiations. So I think that's probably what has been one of the keys of success.
So do you see your role as an advocacy role then?
100%. I think you mix the politics, the nuance of being an insider into the system, with the advocacy or the grit of somebody who's trying to also champion, because let's be honest, people of any condition don't really have a voice in central circles. I mean, there's a lot of chat, but we do a lot of tick boxes of getting people, but we don't. People are making decisions, and what I always also say to national leaders is that you need to own your decision. If you're going to make a decision that you're not going to provide a service, stand by it, put your name to it, and we get really scared of doing it, and thereby people get even more suspicious of what is happening. While when we started the journey with Freestyle Libra, we were very clear. We're starting with 20%. And of course, there was criticism and stuff, but now we're here at 90, 95. So it's one of those things, I would say. Advocacy is very important as to the role you hold.
Yeah, absolutely. And I think something you said a moment ago about, it's not that I don't want to do it. It's being honest about that. Your intention is, of course, I'd love to do all of this, but we've got to be realistic. We only have so much resource, and we have to make choices. And like you say, people understand that. There shouldn't be a fear in the same way around that. People who aren't being offered what they want to be offered will obviously be disappointed, but people do understand the workforce and resource issues, because we all deal with it on a daily basis, don't we, in our lives, kind of, limited resources and managing that. It's not a unique thing to be able to understand. Yeah, thank you. And it's quite interesting you spoke about honesty, because that was my next question. It was all about honesty and the power of honesty and how you use it. And you do speak very honestly with all of your audiences, whether you're speaking at a conference or one-to-one. You're very consistently honest in your approach and open, and you celebrate success and progress with the community, and you also talk about where there is progress still to be made and where the system has failed, and very honest like that. And I think that's fairly unique, and I suppose from an outsider's point of view, it seems like that works to build trust, but it also breaks down this kind of barrier between the system and patients. It breaks down a barrier, it sort of levels it up so everyone's part of the same conversation, because you're being honest, you're talking about the challenges. Do you think healthcare leaders can be quite fearful of that kind of approach, kind of adopting it themselves, but also of your approach in doing that? Do you think?
Oh, 100%. I mean, the number of people who will come up and say to me, I really admire what you do. I was going, well, why don't you do it then? And people go like, oh, you're very unique. And I always say, well, you made me unique because none of you are doing it. It doesn't have to be unique. Yeah, you don't have to. It doesn't have to be unique.
Yeah.
And I always, I'm a big believer in results, in the sense of, how are you as a leader? You got to, in a healthcare system, right? You got to be accountable to who you're serving based on outcome. There's no point in saying I created a few documents and times were tough, and I think people respond to that I will, if it's failed, then I'm the one taking the hit. If it succeeded, then, you're all part of that journey. And I think a lot of national leaders really struggle with that, right? And it sort of percolates in every layer. I mean, I'll give you one very good example of in the present times. Your workforce is under so much distress. You can see it coming from all quarters. I mean, forgetting the pay debate for a minute, it's also about basic working conditions. People will say, hey, listen, I don't have hot food at work. I don't have a place to sleep after I do my nights. And I think NHS leaders can do far better. You can't say on one hand, we're really worried about the morale of the staff and then send them, I don't know, some ice cream lollies because the sun's out. When they're going like, no, I don't want ice cream lollies. I just want some hot food while I'm doing my shift at 2:00 in the morning. Yeah. So, I mean, there's no harm in coming out and saying, as a leader, we fully support that view. And we will work with the government to make sure that every hospital has got a hot food service for all our staff working out of hours. But we don't do that, right? We have got workforce departments and leads and stuff. And if you're going to stay completely silent on these issues, the people notice.
Yeah.
And I think there's no harm. You're not, disrupting any relations with anybody if you say, I care for my workforce. So that's a very good example to me, where I always say is that there's no harm in coming out and giving your support to them. People appreciate that. So that's where the honesty, I would say, that's where it comes from.
Yeah. Thank you. And so something else I wanted to touch on was how you use infographics and data in really nice visual ways. So, for example, you'll show a map of England, and you'll highlight areas where standards of care are different, and perhaps highlight the areas where standards of care are lagging behind, or they haven't adopted certain techniques, or patients aren't being offered things they perhaps should be being offered. Do you feel like that has been quite an effective technique? What do you think the impact has been of using those sorts of infographics? It's quite an interesting communication tool.
Yeah, I mean, it's never been popular among some groups. It's only not popular amongst people who are not doing the right thing. That's what I always say. So people who were doing quite well were delighted with those infographics because it showed them to be really good. And we all talk about, I mean, and I think people take things sometimes personally. So when I put something and you immediately get something, well, oh, you can't do that because we've got challenges. And I said, well, of course I can do that, because at the end of the day, why is a person in X not getting the same service as in Y? And you need to explain that to the population needs to know. It also puts a lot of power back in the hands of the people, because they're going like, hang on a second. We've got the national lead saying that if you're in Derby, Portsmouth, and London, you'll get this, but why am I not getting it if I'm in X and Y? That puts a lot of pressure on people. So I think we do this continuous thing in the NHS whereby we keep things hidden because we believe that's the right approach. I can absolutely confirm it's not the right approach. And recently there was a paper in the FT, the Financial Times, talking about how difficult and impossible it is for the NHS to spread technology. It's not. We have, right, all across the board. And I always talk about the NHS approach to technology is, we talk about the innovation curve, and the NHS doesn't have a way to deal with the laggards. They just don't know what to do with it, right? So the NHS approach to any technology, any medicine, any innovation, any safety measure has been, we'll give it to the people who are already convinced, so they're already taking it. That's not a problem. We didn't need to go and show them any data because they're so committed, they're so driven, they're on it. And then they will go to a second group of people who go to show us the data, it makes a difference, and they will take it. But there's a huge group of people who go like, well, I don't believe that. And
what happens? How are they accountable?
NHS has no way. It's the whole principle. I mean, if you take, for example, any protected characteristic like racism, sexism, or whatever, right, with staff, the NHS approach to all of that has been over the last 7-8 years, which is like, here are some data, guys, it's really bad. Can you do something about it? Guess what? The people who were already committed were doing it anyway. But the people who never changed, they've never had any accountability on it. So overarching, then what happens, you can see the data sets have been flat as a pancake. So you need to bring, that doesn't mean shouting at people. That doesn't mean, and I think that's what people mistake. Accountability isn't just going and shouting at people and being angry at them. It's also about having the data in the public domain and saying, what is it that you're missing, right? Let's bring that accountability out into the open. And we do a lot of that in the safety space with diabetes, insulin errors. We sit down with old systems and we talk about, why is it that they seem to have cracked it and you haven't? What is it that you're not done, right? And then it comes out, oh, they forgot to have a self-management plan and all that sort of stuff. And that's important. So
sharing that learning across and supporting people. Do you get people, when you share that data and say there's an area that is lagging behind, do you get people ever contacting you saying, help us, we want to do better?
Yep, 100%. I've always said there are generally 3 or 4 types of people when their data looks really bad. The first group of people will be, thanks for this, we are on it, we were not aware of it, leave it with us, we will tackle it for you, right? And they're very honest and they appreciate the data. There's a second group of people who will say, where did you get the data from? Okay, can we they're not against it, but they want to cross-check the data. And when they will come back and go like, you know what, actually you're right, so let's handle it. And then there'll be a third group of people, and they will be very much the group you say, all right, found the data, do you have any examples, right? And because we are struggling, so okay. And then there'll be a final group of people who will say, don't believe the data, it's not a priority for us, we don't want to do it. Don't want to engage, don't want to do things. So you have to have different styles and approaches as you go along to it, which is where the public domain comes into play, right? And you say, okay, well, we'll then put it in the public domain. You're not fussed about your patients coming in and having insulin errors, which is the 3rd biggest error in hospitals.
Right.
Which they go like, well, that's not quite what we said. So, okay, well, how do you do it differently? So that sort of stuff.
It's a shame to get
It's a
to
shame.
that point, isn't it?
It is a shame.
I think it's interesting that third group of people saying we are struggling. Have you got examples? Because I think there has to be space for that, hasn't there, within patient safety, of being able to put your hand up and say we are struggling and we don't know what to do about it. And can we share something? Where has it worked well? Because we are really limited for
Yeah,
time.
yeah,
We are really
yeah.
limited for energy and money and everything. So let's see where it's worked and share it. And that's something that we feel quite passionately about at Patient Safety Learning, and about sharing that learning around safety. So I think that space is really important. It's quite an interesting group.
I think it's the defensive mechanism which kicks in for people. We cannot be wrong. I don't want to be shown as being mistakes. So I think that honesty needs to be there. Is that okay? It's not working, right? Whatever we're trying is not working. And I think I always say this in the space of, for example, when they're tackling racism. Just because your data is bad doesn't make you racist, right? The data might be bad because you haven't tried the right initiatives, or whatever you're trying hasn't worked. Start again. Take a fresh guard. Try again. Try different things. And you learn from it. So when we're talking about uptake of technology based on race and deprivation, what I've said to everybody is that there are some things that won't work, but we need to share that to everybody so that nobody does that again, right? Because you go like, that's just silly. Don't do it. This is why it did work. But there are some things which will work. So what is it? So I think the NHS is very scared to show any failures. And I think that's the problem, is that because they feel like if it's a failure, that means I'm not doing my job and I'm bad. No, failure is part of the process. Innovate. If you, and in the world of, for example, innovation, if you haven't failed, you haven't done innovation. That's not innovation, because that's the whole principle of it. You got to fail. So, and I think that's what I encourage leaders to come out and say, okay, this project of mine, and I say very openly about projects which haven't worked for me. Didn't work. So we try again. So we tell people, so what you do is pass on the information to others and go like, don't try that, because that approach probably won't work. So that's it.
But do you think leaders are do you think there's pressure on leaders not to talk about failings
100%.
from anywhere? Or do you think it's an internal pressure?
It's a combination of both. I think we, as a system, have been built up to say, so, it's like, it's not very far away from being an ostrich, because everything's collapsing around you and you're turning around and saying everything is fine. And everybody, but what happens, the leaders lose their respect when you do things like that, right? So if you come around and say, for example, there's a 75th year of NHS coming up and lots of people are going to celebrate that. It's brilliant. The NHS is brilliant. And people are going like, well, I can't see my GP for love or money. I can't get a hospital appointment for love or money. Why are you keeping on saying it's brilliant, right?
Yeah.
So you need to have the balance that doesn't jar in people's faces and is so out of sync. And I think that's where NHS leaders struggle a lot. And I think we're not trained. We're not trained to deal with failures. We're not trained to deal with putting your hand up and saying we've got it wrong. And that reflects a lot amongst a lot of people afraid to say what's happening. Inherently also, nobody likes to admit to having got things wrong. So you have that sort of debate as well. Is it right? Is it right? So that sort of goes around in circles a little bit.
Yeah. And I think when leaders speak up about failures, it's only going to have a positive drip down effect,
100%.
isn't it? And creating that kind of speaking up culture when things go wrong.
So it's not very uncommon, if I'm honest, when I go to meetings, you succeeded, so many projects, they're all successful, right? You're doing this, everything you touch. And I always go like, okay, I can tell you what, I could spend a whole hour talking to you about projects which have not got off the ground, which have failed. I'm very happy to come around and tell you how many interviews I've been on, not been shortlisted, not got selected for jobs, because I'm inherently very confident. As people assume that when I go for a job, I immediately get the job. I don't. There are many jobs I've gone for, but they're going, well, not quite sure. Fine, and that's how you do. So I think there is that sort of thing where people have to speak a little bit more about what hasn't worked for them. So it's a balance of things, as I always say.
Thank you. And I suppose you've spoken about this a bit, but how do you influence decision making within, you spoke about those kind of inner circles. How do you influence decision making? And are there any kind of techniques that you would share that have been particularly effective?
So I always say, I alluded to the 4 groups of people you meet, right? And I think tactically the NHS gets a few things wrong. So there are 4 groups of people. So you bring a project or bring a intervention which you think will improve. Let's take safety, and you go, right, this will improve safety. And you got group 1 who will go, brilliant, love it, we're on the case. Group 2, show us the data, this intervention works. Group 3 who are like, If everybody's doing it, I'll join in. And then finally, oh, we don't believe this, right? And the fundamental problem that the NHS gets involved in, they try a lot on group 1 who are already in, and then group 4 who are not convinced. So you spend your time trying to explain to them, right? So I think the biggest group is your group 2, right? Who wants to see some evidence base because clinically mindset, etc. Most people will come around to, because then if you got group 1, 2, and 3, you got your critical mass across the NHS, right? Of people doing the right thing. The only way you tackle group 4 is with data. You expose it. You basically go like, okay, which is what the maps you referred to came into play. Area X and Y, they basically say we're not doing it. So it's like, okay, well, let's see how long you hold out. So then what we did, we produced a map of England whereby there were the only 2 areas which were red. And it was not even amber. It was like everybody else was green. So I said, and I named them, I said, these 2 areas, lowest uptake in the country. And as you would expect, within 24, 48 hours, had contact saying that we wanted to meet and discuss, etc. So you're pushing the sort of boundary, say, look, we've tried with you. And at one point you turn around and say, I think the only way I can bring accountability to this is with open data. But you keep on saying this, you have different strategies as you work with people. And I think my advice would be, don't spend too much time on the group 4. If you get to a point where you are really struggling with it, leave them. Focus down on your critical mass. If you get past the critical mass in the NHS, the others will fall in place.
Interesting. Just in terms of communications generally, that could be applied to anything, actually, your kind of the groupings around that. So I mean, I would say you generally, your default is a very positive nature, very positive attitude, but clearly there must have been huge frustrations in the work that you've done around diabetes, but also in the work you've done around racial inequalities and racism. How do you, what advice would you give other people who've shared frustrations, or I suppose, what are the frustrations that you've come up against, and what advice would you give to other people who meet similar kind of barriers?
I mean, I think I give advice on that line. I sometimes don't quite always follow it, but I think it's quite important to have structures around you which will take you away from that world for little bits, right? Whether they're your incredibly close friends, whether your family, whether it's your dogs, whether it's your movies. I call them little bubbles of life, whereby that work. So you need to take timeouts. If that makes sense. And I don't just mean holidays. There can be little timeouts, like a Friday evening or a Thursday morning, whatever, when you're going out with your spouse or your partner or just your best friend, right? Whereby you just sat down and had a coffee and nothing was about work. I think they're very important to take fresh guards because they do consume a lot of your work and time and mind. Okay. So I've always built those little bubbles, if that makes sense. And sounding boards, but not too many. Not too many sounding boards because they can confuse. So a couple of really trusted people you can just rant your frustrations at, who will just listen. But more importantly, I think sometimes I've always said it's about fresh guards. Sometimes some days will be bad and you try again, but you need a break. So it's not on your mind all the time. And people always say that means leave and weekends. No, it doesn't. It means breaks in the middle of the week, taking a bit of time out, going out with your husband, wife, whatever, whatever. Just have a little break where you're not talking about work. Okay. And I think they are very important to build that sort of level of resilience. It is important because you can hear the dogs bark in the background. So resilience is a much used word, but we don't quite understand that resilience comes from your loved ones. And I think so frustrations have been many, but you have to, and I think it's also about that thing where you go like, what is my target, right? It's also about, and this is what I say to everybody who will listen this, is that never do anything which at the end of the day you feel will destroy you or your own well-being. Nothing in the world is worth it. Nobody remembers a martyr. All right. So I think whatever be the project, and if it's your passion, maybe this was not the right time if it didn't work out. Maybe you need to come back to it when the strength is a bit more. But never do it to the point where you go like, I need to soldier through this because I have to. No, don't have to. I think you are most important, and I don't say that glibly. I've been through tough times, but I've got a very supportive family around me, a lovely bunch of friends all around, and they always do look after. They know they can pick up the signals very quickly, and they go like, I go quiet, and they will go like, come on, let's go out for a few, let's go for a meal, right? So I think they're important is to have yourself surrounded by that sort of really trusted people.
Yeah.
Who are there to, and who you can phone up and also go like, do you want to catch up for let's go for breakfast, that sort of stuff. That's would be my advice to people. The job is tough. It's supposed to be that. But don't get sucked into it so much that you destroy yourself.
Absolutely. I think that's quite a nice place to finish. Excellent advice.